ahead and get started. Some other folks may join us, and that will be great. I'm Karen Emmons. I'm a professor at the Harvard T.H. Chan School of Public Health and one of the co-leads of the Dissemination and Implementation Incubator here at Harvard Catalyst, along with Nitish Chowdhury and several others. And it is my absolute pleasure to introduce our speaker for today, Enola Proctor. Enola is the research professor and the Shanti Kenduka Distinguished Professor Emeritus at the Brown School and Center for Dissemination and Implementation at Washington University in St. Louis. I'm not going to read to you her accolades or say very much. We sent out an announcement with her background, but let me just say we have implementation science as a field because of Enola Proctor.
Oh,
Enola Proctor was so instrumental in developing this field. We're so lucky to have her with us today. She has just been such a leader, such a visionary. And now she's reflecting back on the field and taking a look backwards to help us go forward. So it is just such an absolute pleasure. So with that, Enola, I'm going to kick it off. You're going to talk for about a half an hour or so, and then we're going to open up to questions. Our Slido is open, so I think we'll get that in the chat if it isn't already in there. So put your questions in there, and I'll moderate when we're on the other side. Welcome, Enola.
wonderful. Thank you, Karen. And the honor is mine to be with you today. You all are so fortunate to have Karen leading this effort and leading the department at Harvard. And I've followed her work. We did training together in a number of programs, and I would say we've learned together, we've taught together, and it's certainly, I'm a great admirer of Karen's work. So I'm really happy to talk to you about a topic that I've been intrigued with for over a decade now, and that is implementation outcomes. And I'm going to briefly talk about some of the early work we did, some of the key points of a paper that we published in 2012. And I think you'll see some inconsistencies, whether I refer to that as 2012 or 2011 because of the EPUB ahead of print. And so pardon my sloppiness with that. That paper, we tried to propose a number of questions for further research. And in this most recent paper, we've looked back to see what happened in response to the questions that we put out there. And then try to assess where we are now and what's ahead. So how did this start? Well, I was working in a role that I guess I created. Sometimes I get myself in trouble by proposing, let's do this. And people say, okay, you do it. So I proposed that our CTSA way back, probably 15 years ago, have a core in implementation science. And I deliberately structured that core as a research core focused on methodology. And my goal was to entice investigators at Washington University School of Medicine and throughout the campus to begin to pursue implementation science questions. To do so, I established a consultation service where I gave a lot of dog and pony shows. This is what implementation science is. These are the questions that are being asked. Here's the relevance to your department. But also worked with individual investigators to help them write implementation science grant applications. And my real goal was to increase our bench at Washington University in terms of investigators writing high quality and very successful implementation grants. So as I set out to do this, I thought, what should these grants look like? What should they be measuring? How can we demonstrate the success of implementation? So I began to think about, how we typically think about research. And most of these investigators were clinical investigators, some even bench researchers, but many clinical and intervention researchers who were working with a quality improvement or an empirically supported treatment or intervention that they hoped would improve patient outcomes, whether it be their symptomatology, their functioning, their satisfaction with services, or their improvement. So the scene that I found myself immersed in although I was doing implementation research in the space of behavioral health at the School of Social Work, at the medical school, I found myself working with investigators who were pursuing a really traditional effectiveness research agenda. So what would be new for them, and what did I potentially have to offer in moving them from being intervention researchers to implementation scientists? So, of course, our team had identified that it's not only the what that we want to implement, but we need another kind of intervention or other tools. And those we characterized as implementation strategies, or the how we get the what into place. Also, we realized that there were other outcomes that were necessary and would contribute to better functioning health systems, the delivery of health care, and without improving the delivery of health care, we couldn't really expect to achieve clinical outcomes. And I remember a student in a class that I was teaching at the medical school in implementation science saying, "Oh my gosh, this is the first class I've ever taken that's not about the human body and medicine and intervening in humans. But, now we're talking about intervening in systems of care." So this was really the core of implementation science. And at the time, the literature was not very well advanced in articulating implementation strategies and implementation outcomes. And therefore, my own thinking was challenged to add some clarity. And I often say I write papers to figure things out myself. I rarely write about what I know, but I write in order to clarify, to sharpen my thinking, and to end up knowing more than I knew when I set out to write the paper. I hate to tell you that. You might think that you should read my papers to know what I know instead of what I didn't know, but in all transparency, that's really the fun of doing research and learning and growing. So I assembled a team. It was a multidisciplinary team, a couple of physicians, systems scientists, organizational researcher, and some of my students at the time. And we reviewed the literature and came up with the constructs comprising 8 implementation outcomes that we saw cropping up in the literature. And we offered a definition of implementation outcomes as, first of all, indicators of implementation success. Now, this is not the indicator of an intervention success, but it is an indicator of getting an implementation of those interventions in place. And that they are proximal indicators of implementation processes, or in other words, they're quite immediate, and in turn that they serve as intermediate outcomes per the diagram that I showed above, in that they contribute to more effective health service delivery. They certainly contribute to equity. If we deliver interventions that are not feasible or not acceptable to groups, and we insist on pushing ahead with that, we're leaving people out, and our health systems are not going to be very equitable. So that was the kind of the framework that we proposed in this paper, that implementation outcomes contribute to a set of outcomes that at that time, the Institute of Medicine, now the National Academies, had proposed that we need to pursue more efficient, safe, effective, equitable, patient-centered, and timely systems of healthcare delivery. And that only by achieving these things can we really expect to see individual and population level improvement. So as we reviewed that literature, actually, I remember convening a meeting of our whole team when we had a draft, and I said, do we really have anything here? Because we found quite a jumbled kind of language. We found that the field had really not been measuring implementation outcomes distinct from patient outcomes. And we found that some assumptions were being made that interventions and implementation were not successful because people weren't getting better. We said, wait a minute, that really, that's a jump, because if an intervention isn't implemented with fidelity, penetrating a system, if it isn't implemented in a way that's acceptable to the users, why should we expect people to get better? So we thought it's really critical that we examine these intermediate outcomes, and that in fact people's preferences and their priorities matter, and help contribute to person-centered care or personalized care. So we felt that implementation strategies are really critical for attaining implementation outcomes, and that's why we call them outcomes. And early in my thinking, I thought, these are really showstoppers. If people can't afford the intervention, there's not going to be implementation. If it's not feasible given the resources of a health delivery system, or if it's not feasible for people to follow, or if it's not acceptable. There are a lot of interventions that it's tough for providers to deliver. Certainly trauma care, exposure therapy for trauma, that's tough for therapists to deliver. So we need to look at these intermediate factors to really understand what's contributing to or what is impeding successful implementation. So again, we can have a very effective intervention, but if that intervention is not understood by the providers, if it's delivered with poor fidelity, if providers cherry pick and only deliver the intervention to individuals that they think are highly likely to have a positive response, or if people start delivering them but really drop off the fidelity or drop off the intensity, then we're not going to get to those outcomes. So as we wrestled with what we found, we proposed, and this was in addition to our identification and definition, we proposed that there be some consistent terminology, and therefore we proposed, and what we said was a tentative or an iterative taxonomy. We fully hoped and expected that new implementation outcomes might be added to this over time. We felt that the paucity of research and the little attention that had been directed toward implementation outcomes signaled a need to really understand the mechanism of change and to build theory about this. And that we certainly needed more robust measurement. I think as a field in implementation science, and particularly around implementation outcomes, we over-rely on self-report. And we need more robust testing. How are implementation outcomes interrelated? I knew from my own practice experience that if people thought that a client would not accept a particular intervention, and I had this experience with depression care for older adults, because even the providers bought into some ageism and said, well, why wouldn't they be depressed? And so they're not going to accept the treatment. But when we showed that people did accept it and did improve, then we had greater acceptability at the provider level. So what is their interrelationship, and what's the effect of implementation outcomes on other outcomes? Where is the research that shows that if we attain implementation outcomes, service system outcomes improve and people improve? And finally, how do we achieve them? What strategies are effective for attaining which implementation outcomes? So the paper contained as many questions for pursuit. And that team meeting that I called right before we sent it off, I said, should we really publish this? We haven't solved anything. We're shining a light on the state of the field, but we said, took us almost 2 years to pull this together. Let's get it out there and see what happened. So what did happen? Well, we were quite surprised. because the field did respond in terms of advances in conceptualization. There have been a number of papers that have linked implementation outcomes to CIFAR constructs that have sharpened distinctions that we first proposed, such as the difference between perception and behavioral indicators, attitudinal factors in implementation outcomes. There have been another number of measurement advances, and the NIH program announcement for dissemination and implementation research in health began to say that if you're doing an implementation study, you need to be measuring implementation outcomes. So we were quite gratified and surprised by that. These are a few, and you'll have these slides to review, a number of reviews of different measures for different kinds of implementation outcomes. But actually, I need to credit a co-author on our 10 years retrospective paper, Rebecca Langnick Hall, who is an assistant professor at Washington University. She came to WashU to start her postdoc in our NIMH T32 program. And she proposed that some topics for us to work together. And I was most excited about her idea that we might reflect back 10 years after the publication of that paper to see what had happened. So the resultant paper, and there are 2 or 3 other papers that are related to this that I'll mention, was a scoping review of implementation outcomes. So not because we were arrogant and thought people needed to pay attention to us, but because we thought it was only fair to ask people who had actually read the paper whether they had addressed the research questions that we proposed. In other words, we didn't want to critique articles that didn't know anything about our paper for not advancing some of the research agenda issues that we put forward. So we used forward citation tracing in a couple of search systems and databases, and identified 1,300 records that had cited the Proctor paper, but we also required that it be empirical research that actually measured an implementation outcome. And so when we did our various exclusions through our criteria, we ended up with 400 records or 400 papers. They were published in journals globally, supported by a variety of funders, and we have that data in the paper. The bulk of them, the modal focus was the implementation of one single intervention or evidence-based program or initiative. And 2/3 of them used observational designs. And I'll dig a little bit into this in my critique later. So one of our basic questions, well, who's studying which outcomes? And we found that acceptability was the most frequently studied outcome. Feasibility, fidelity, and sustainability were also studied. We had proposed in the 2012 paper that certain implementation outcomes were likely more relevant to certain phases of implementation. But, you know, we just made that up on the basis of theory and our thinking and in 2012. So in the 2022 paper, we were able to actually examine this, and we did find, in fact, a very marked distribution of attention to outcomes by different phases, and we used the EPIS framework to identify the phases of a study. I was most interested in the outcomes role in analysis. If you'll remember, I proposed some questions about how are they interrelated? What are the effects of achieving an implementation outcome? And how do we achieve implementation outcomes as dependent variables? And so my disappointment was that the blue bar, as the blue bar reflects, most of the studies were simply descriptive. That is, they would say, this intervention was acceptable. This particular implementation outcome was acceptable in this setting at this time by these respondents. The red bar shows the percent of studies in our sample that looked at the relationship. In other words, is feasibility related to penetration? Is acceptability related to actual adoption or sustainment? Is cost related to sustainment? We certainly need more research here, as you can see by the rather sparse attention reflected in those red horizontal portions of these bar charts. The green slivers represent that implementation outcomes served in the role of an independent variable in relation to some other factor. In other words, did acceptability lead to better patient improvement? Or did feasibility lead to more timely care? And again, we see very little research looking at that. And finally, the purple bar reflects implementation outcomes as a dependent variable. That is, studies testing the relationship between various implementation strategies and the attainment of a particular implementation outcome. This left us with the following thoughts about the state of our current research on implementation outcomes with respect to theory building. We don't have a lot. Only 5% of studies looked at the relationship among various implementation outcomes. Only 5% looked at the impact of implementation outcomes on service system outcomes. And among those service system outcomes, I was quite disappointed that we found no studies that looked at the relationship between implementation outcomes and equity. I mean, do we really think that acceptability and feasibility are not, or adoption is not related to equitable care? I think it must be. And so we need some data to back that up. And none of the studies in our sample looked at safety. And, even psychosocial interventions vary widely in their safety or their potential harm. And then finally, what was the research looking at implementation outcomes in relation to client outcomes? 5%. And again, a low percent, about 14%, tested implementation outcomes as a function of employment of implementation strategies. So I know I went through that pretty fast because I'm trying to keep my comments to about 30 minutes. Happy to back up, answer questions, go revisit points in our discussion points. But because I'm an optimist and I hope I'm a careful opportunist, there's a lot of work to be done. And I'm hoping that those of you in this program will want to contribute to the work, to contribute to what we know about implementation outcomes and their contribution to achieving better health systems and contributing to better well-being at the individual and the community level. So where do we go from here? I've probably foreshadowed that, but we have a table in our paper that kind of pits the 2012 paper against the 2022 paper. We challenged in that first paper, use consistent terminology when you're describing implementation outcomes, report the referent for all implementation outcomes. Was this captured from the perspective of a service user, a service provider, a supervisor, or the director of a service system? And did it refer to an intervention or to a strategy? Because just as interventions can vary in their acceptability and feasibility, so can implementation strategies. So this is was just a a plea for fuller reporting of the details, and also to specify the level and methods of measurement. And we challenged, again, a lot of theory building by answering some of these questions, and also looking at, which stakeholders care most about which implementation outcomes. We think that administrators and CEOs are likely to care about cost, and likely to care about the penetration. Is everybody being served in our health system that needs a particular intervention? We think providers probably care a lot about the feasibility and the resources they have, the time they have, is deploying this intervention or learning to use this intervention through a given implementation strategy. Is it realistic? Does it fit within their workload? And to clients and patients in our health systems, we think probably the acceptability is critically important. But again, we challenged that there be advances in conceptualization, measurement, and theory building. Now, we found the coding to be quite challenging, often because there wasn't enough detail. And we had a process. We had 2 coders for each article, and we consulted when we needed to square our assessments with one another. And we found that in these Zoom meetings, we were often just griping about an article. Oh, why didn't they report this? And I can't figure out what they meant by X, Y, and Z. And in one meeting, I said, why don't we turn this griping into some recommendations? Let's detail the issues that are making this coding challenging. And so our research team, we began to document how clearly were things reported. And Dr. Langnick Hall led the preparation of this paper that is published with 6 practical recommendations, and it also has a tool for assessing the clarity. And we hoped that editors and reviewers would begin to go back to authors and say, can you provide more detail here? So this paper reports, details kind of what got in our way with our ability to code reliably, and what was fixable, and then how can we help the field report more clearly by offering these tools. So, clearly, better reporting is an area that we need. We also need to map the mechanisms through which strategies might lead to different implementation outcomes. And we have developed this grid to identify in the first column various determinants. There could be a deficit in a provider knowledge or skill, or the clinical care options aren't standardized. And therefore, what do we need to, what's the mechanism of change? And what are some strategies that might help address those deficits by producing change through the identified mechanisms? And then which outcomes is that likely to lead to improvement? So our team was challenged. Actually, somebody asked us to give a presentation saying, well, of all the implementation outcomes, which one should you focus on for your study? And, I was kind of horrified at right after this study came out that people said, I'm having trouble measuring all 8 outcomes in one study because it's so much measurement burden. And we never intended for the 8 to be a prescription that measure all 8 in all studies at all times under all circumstances. So we went back to our thinking, and you're going to benefit from the questions that arose in that other presentation. We put our heads together and began to think about, in light of that table that I just showed you, how you might think about choosing a particular implementation outcome for focus. Well, first of all, think through the barriers, and those were the determinants. Is it that people don't understand an intervention and therefore they're not picking it up and they're not wanting it to deliver it? And then consider the implementation stage or phase that your research, question, or project is situated in. If any of you attended the D&I conference in December in Washington, D.C., one of the panels really highlighted, should we be worried about sustainment early on? And some people said yes, or we're going to not have in place the factors that contribute to sustainment. And there were, another view was we shouldn't really try to institutionalize something unless we know it is implementable and it is acceptable and it is feasible for delivery. So think through, where are you in the implementation stage and which implementation outcome seems most pertinent for that project at that time. Then certainly there's rich theory about behavior change, about organizational change, about system change. And those theories are really packed with ideas about the mechanisms of what needs to happen to get from point A to point B. And so those theories might, one theory might say, you have to have a favorable attitude before behavior changes. In fact, that's kind of a basic psychological theory. And then you might say, okay, we need to work on acceptability before we think that people will change the behavior. Other people might have a theory of behavior change, might follow a theory that says we change behavior and over time people become accustomed to it. So let's focus on changing the behavior first, in which case you might focus on feasibility and adoption and monitoring until something becomes routine. And then people say, oh, I do like this after all. So again, a theory will point you to to various ideas about what should happen in what order. And then reflect on and use your practice experience. I think we all learn so much from our implementation projects and bring them, hopefully every project I do benefits from the project that I just did. And then certainly look at the implementation outcome literature in your area. We have a lot of different practice settings. I've done research in critical care settings, and they are certainly unique. Their dynamics, the urgency, the timing, the pace, the staffing is very different than an intervention delivered in a community clinic. So think about, and there's a growing literature in implementation science for various settings. And then finally, think about whose perspective you want to capture and include in your assessment. So my takeaways, we have lots of descriptive. We have a good mix of qualitative and quantitative, which I think is really important because those qualitative studies can yield so many theories for further testing, or they can really reveal nuances that are data merging and qualitative research overlooks. Here are the areas that we need more research for. So again, please measure your implementation outcomes separately from other outcomes. We need research to identify strategies to attain them. And finally, for our field, we really need to demonstrate how successful implementation matters. I think that most hospital systems will not truly value their implementation researchers until we can show that if things are implemented well, their health system will be more efficient. There'll be higher patient satisfaction. Maybe there'll be less provider turnover, but I think we're a ways from having the data to demonstrate that. So many opportunities for you. I hope you leverage these opportunities and contribute to this important field. And thank you so much for your attention. And I'm all yours for discussion, questions. and
And
thoughts.
Nola, that was spectacular. Thank
Oh,
you so
thank you.
much. That was just such a tour de force. So grateful to you for being here with us. We can probably stop your slides so we can see folks. I'm going to kick off the conversation with just a couple of questions, and I'm going to go to Slido. So if you have questions, put them in there. We've got a lot of them in there, so we'll go ahead and put those forward. Anola, do you want to stop sharing? There we
Yes.
go. Perfect. Um, so, what this paper and your presentation reminded me of was some advice I got when I first came to Harvard by my wonderful mentor, Fred Lee. And he said, when you're trying to plan as a junior investigator, you're trying to plan your career, walk over on a dark street to the lamppost and look where the light is shining, and then turn your gaze outside the light and focus on the areas outside the lamppost light. And that's exactly what you've given us here. As you've said, everybody's looking here, look over here. Here are all the spaces that really deeply need focus and rigor. And so for that, I think all of the junior investigators and some senior in this group are very grateful, because I think that just really gives people a sense of where the field really needs to go.
I love that. Thank you, Karen.
Of course. I was really surprised myself that so few studies looked at clinical outcomes, because that's such a tradition in our research fields for people to want to look only at clinical outcomes. So I was really surprised. Why do you think that is?
I puzzled about that too. And um, sometimes I've wondered if I contributed to that myopic view. Um, because early on, I was among the voices that said implementation science is different. Remember the shaded circle that I put over the effectiveness research. And we said we have distinct strategies that are different than interventions. We do distinctions in outcomes. So I may have been among the voices that led us to look at our navel. And yet I thought I was offering a framework that said you have to look there to get to what really matters. And I'm not saying implementation doesn't matter, but that's not our goal. That's a means to our goal of improving our health systems and improving the health, well-being, and satisfaction of people who use those services. So, it could be that, in our perhaps necessity to carve out the distinctiveness of our field, that we did shine a spotlight on the immediate needs. And every discipline goes through that. If kind of look at the history of every new discipline, there's a need to sharpen, our identity, our methods. But our methods need to be in service of the larger goal.
Yeah, totally agree. Natish, do you have a comment on that?
Yeah, I did. Enola, thank you so much for joining us today. This was
You.
absolutely fabulous as an accidental implementation researcher, and now somebody who spent a lot of time thinking about this. Your work has been an inspiration to many of us. I wanted to propose an alternative view of the agenda that you put out, and I very much appreciate the thoughtfulness of the idea of there's so much more for us to understand, and that here's a roadmap to do so, and let's be scientists about this and go about and sort of advancing the field further. And I think that's certainly how you build a field. But my alternative narrative is what you and others have helped do is actually help people understand that these are important things to measure in and of themselves. So the idea of acceptability, independent of whether it's linked to mechanisms or linked to clinical outcomes or linked to service outcomes or whatever it may be, the idea that we would actually measure these things and consider them to be important is, to me, in and of itself, victory enough. And that doesn't mean there isn't more to do, but if there were a first priority, it would be that, and then the second priority would be some of the mechanisms. And I'm wondering if you have any reaction to that, or take any solace in that, at the very least.
I do take solace in it and I love it. I came to implementation science as a social worker. And one of the key principles of social work is to establish a relationship in which the people we are working with are respected, first and foremost, are listened to, are valued. And therefore, when PCORI came out with their emphasis on patient-centered care, I thought, yes, this is what we need to be doing. And our I think our insufficient attention to those intermediate outcomes and those implementation outcomes um, um, may reflect why so many people feel alienated from the healthcare system. Um, I don't want to go too far, but, we had a horrific example of how people feel about the insurance industry. And many people feel that way about the healthcare system. They don't care about me. They don't listen to me. Um, and Be careful if you ask me a question because I can just go on. I remember being invited to give a talk at a major health center in March of 2020. And people said, well, there's this new thing happening. It's COVID. And how do you think about COVID from an implementation perspective? And it might have been April because, we were beginning to have to comply with all these mitigation factors. And I saw, lack of acceptability, lack of appropriateness, lack of feasibility. I mean, those of us who could work from home were highly privileged. Those of us who lived in single dwelling facilities where we didn't have to ride an elevator and encounter people. So, many of the mitigation factors were just immediately, I saw them as not feasible, not acceptable, not doable, not cost reasonable. And so when I was giving this talk, I was giving these examples and I said, and there is work to develop a vaccine. And I think we need to ensure that people understand the process of developing this vaccine. And, the person who was moderating said, well, what would that even look like? And I said, well, I knew this group very well. I knew they had vaccine developers. And I said, I think we need to be engaging the community in the process of vaccine development. And they said, well, we don't even have a vaccine. Why would we start talking to people about, how the vaccine, we don't even know if there will be a vaccine. And I said, no, but this would engender understanding and trust in the people whom hopefully we're going to be asking to take the vaccine in 6 or 12 months. So, my social worker heart, my social worker mind, appreciate your observation. And I think these are in fact worthy in and of themselves.
Yeah.
Thank you.
Thank you,
Perfect.
Enola. I'm going to take a couple questions from the Slido and then I'll come back to the room. Travis Moore asks, there's a growing discourse about the importance of mechanisms in IS. How do you see the field advancing in its understanding and measurement of mechanisms?
Yeah. A lot of people are talking about that, and I try to get on board with that. And I think it is important to some constituents. I think it's primarily important to researchers, and this could be controversial. I argue with my friends who are deep into mechanistic research, and we have an implementation science meta science group here, and we meet every other week, and we discuss issues that are cross-cutting across the field in terms of scientific advances. And one opinion was that we need to study the mechanisms of every single strategy. And I thought, should we study mechanisms of things that don't work? And I tend to be parsimonious in terms of thinking we need to invest in what's going to have some payoff. So I think understanding mechanisms is extremely important in understanding how, but more importantly, do things work? Because they can point us to more intermediate outcomes that need to be pursued in order to see the effect of the intervention. For instance, that table slide that I put up, the mechanisms of further knowledge or building confidence or repetition are probably key to many of the strategies in attaining particular implementation outcomes. I think that as a field, we can't do everything, and therefore I think our study of mechanisms needs to be focused on some of the most important questions and perhaps some of the strategies and interventions that we think aren't working so we can figure out what we were missing.
Yeah, that's really helpful. One more from the slide, and then we'll go to the room. Julie asks, are there specific implementation outcomes that in your view remain poorly conceptualized or measures, or are there concepts that you wish you had included but did not? I love the last part.
Yes, I love it. And scale up is one. Scale up it's also it's another way of looking at penetration, which we did capture. Penetration is usually within a service delivery arena. In other words, what proportion of providers are actually delivering an intervention well, to what proportion of the people they are serving. So that tends to be internal to a health system and kind of going down, where scale up means kind of a vertical expansion, which depending on which direction you're looking, north or south, could be the same as reach or penetration. And scale out, of course, is moving from one system of care to another, or one program to another. So I wish we had captured that language. There's also an emerging literature, although I think I saw most of it, maybe I'm seeing less of it now, but it's the usability. Industry does a lot of measurement of usability, and I think we tried to get at that through feasibility, but there's very little implementation science, or certainly there was when we wrote the first paper on usability, but there are some very nice measures of usability. So
Excellent.
again, we think that there's room for new implementation outcomes, so bring it on.
That's great. Steve, I think you had your hand up next, and then we'll go to John.
Yeah, thanks. And all a really wonderful presentation. And it's just great to hear your long vision and also your vision for the future. And I was going to ask you, as I've kind of thought about the field, certainly your admonition that we need to be doing more empirical trials and doing less framework development and theory, I wholeheartedly embrace. One thing I've wondered, though, about is the issue of, one thing is to look at the outcomes, but early on, I think we thought a lot about what's wrong with the ways in which we're putting things in place. How can we overcome barriers, et cetera, which I think makes sense. But there's always the question, and I know you were alluding to this in usability, that maybe we're really failing at the design phase. Maybe so much of what we've failed to do in trying to jam things into place, square pegs into round holes, is that the thing was never designed really for usability, scalability, and uptake and penetration. So I'm wondering about your thoughts about that. Were we looking under the wrong streetlight to some extent? That really the problem was in the system and these primary care doctors who just don't get it? Or did we not get it as researchers in designing things at the outset, or co-designing with our clinicians, with the public, with participatory co-design? And then if that is a really important area, how do we study it better? What can we do to make it work better?
As always, Steve, you've lobbed a number of important points and a number of questions, and I'll just touch on a few of those. Yeah, yes, I think a lot of the problem is the original design and the way, and related to that, I'm a big critic of the push out, and think we need to think more about the shape of what we're pushing out, which is, i.e., the design of the intervention and the design of our implementation strategies. And also the pull. What is the perceived need or the perceived desire? I bristle at the stereotype of, I hope it's a stereotype of the implementation researcher who says, I've got this thing that I think you should adopt. Perhaps because I came to implementation science from social work and from health services research. My first implementation project grew out of and was informed by 8 years of service system research I did with the system of care. I knew their challenges. I had lunch with their providers. I, asked them, what are you struggling with? What are the demands of your payers? What are the priorities of this health system that you're working in? What do you wish you could do better? And, and if we start there, then so even backing up from code design, having user-informed questions to ensure that our work will truly be helpful, which is what we all want. And while I think we perceive that such things as user-centered design, human-centered design are relatively new. If we look back at the diffusion of innovation, Everett Rogers alerted us to the features of the intervention itself as being a key factor in the adoption. And he pointed out some things that, some criteria for that is there perceived advantage? Is it similar enough to what we've been doing that we can get on board? So yeah, it's new, but it's also old, and it's kind of true to what we were doing. And then the latest work that I'm doing with Alex Ramsey and Gila Nita on PACE, we really believe that some of the features of the intervention contribute to either a sluggish adoption or a more seamless, facilitated adoption of an intervention. So thanks for that, Steve.
Yeah.
Thank you. Don.
Yeah, I've been looking forward to this because I've had some modicum of success in getting improvement scientists to start thinking about implementation outcomes.
Good for you. That's terrific.
Yeah, something I don't take any credit's infinitely divisible, but I actually think I've had some influence. Steve actually touched on this in a sense, and so did you, but I'd like to drill down into it a little bit more. I've been really looking carefully at evaluation frameworks and specifically looking at implementation outcomes. And I think there's a problem I see with trainees with the term outcomes. And actually, acceptability, appropriateness, feasibility, usability, these are, as Steve said, these are really design parameters. You don't start, at least in improvement, we don't start a project, we shouldn't, if nobody thinks it has a relative advantage, if nobody thinks it's feasible for their work, if it doesn't fit within their own system. These are things that have to be considered in design and tested in week one. So that's one thing I'm seeing trainees, they just are so focused on outcomes that they don't design with those parameters. Same's true of CFR, actually. Think about it in design, not just in evaluation. And secondly, the term outcome, and you mentioned this, it evokes quantitative measure. Right. I need a number. How am I going to measure it? Can I get a survey that I can turn into a number? When in fact, a lot of those implementation outcomes when applied to design are qualitative. They require qualitative inquiry. So I'd love to see more emphasis on the duality of outcome and design so that trainees won't get trapped in their K award to think, well, these are the outcomes we're going to measure, damn it. And by week 7, we're going to start measuring these outcomes and do it iteratively for a year.
Yeah, I think we chose the term outcome because we wanted to emphasize that these factors are modifiable. And this probably came again from my social work background in part, where there was a lot of literature and also in psychology about clients who are resistant, as if that were a trait. And I push back against the trait notion and think we need to think more about states that we can help attain. So if a particular intervention is, if a client is resistant to that, or a provider is resistant to that, I don't think we just write it off. I think we try to pursue a change in that status. And that's why we called these outcomes. But remember, I also called them potential roadblocks or red lights or showstoppers that, they're going to get in the way. So the language is challenging to figure out, how to characterize them as things that need to be assessed at the start, as you said. We need to think about how do we design something that is acceptable. And therefore, I think it is an outcome because we're asking the question, how do we get there? But an outcome can also be an independent variable in relation to other outcomes. And so I've probably taken you all down in a rabbit hole of
No, this is great.
Isn't an outcome, but this is how I think about it. So welcome to my
So if you
muddied
take one
world.
thing, let me just mention one quote unquote outcome that improvers think about a lot, and that's readiness. Readiness of a team or an organization
Yeah.
to make change. And of course, implementation activities and outcomes should reflect your interventions that improve readiness at the very beginning and
Yep.
continuously. So that one really shows, I think, the duality and the continuum of
Yeah.
what you're talking about.
That's great. We have 2 minutes left. I'm gonna ask one last question from the Slido board. And I think it's an easy lob. Do you have any advice for early career folks who are really interested in this space? What would be your top couple of ideas for them?
Yeah. Know the system that you're working with. Know what matters to them. View your skills, your presence, your energy as a tool to help them. No, providers are not the enemy. Health systems are not the enemy. I don't know of a single person in health or social work or public health or medicine who doesn't want to improve things. So position yourself as an ally, understand the context, and you're in this field because you want to make a difference. So partner with the people that you want your research to benefit, and know the system inside and out. Know the population, know the policies, know the service structure, know the leadership, because what do we say? Context is queen. And I think it's not just something to study. As implementation researchers, we need to know it and appreciate it.
Yeah,
And
that was just
respect it.
spectacular. Partnership is so important. And you've been such a wonderful model throughout your career, Enola, about how to really do implementation science in a way that honors your
Okay.
partners and brings their voice and their needs forward. So we're so grateful for your work. And this was just the best hour. I wish we had 2 more hours. We could, I'm sure, stay here and have fun, even if we were going in well into the night. So thank you so much for your time today. Really, really grateful. And thanks everybody for hanging in with us and coming today.
Thank you. I'm really honored.
Really
Thank
meant a
you
lot
so
to have
much.
you here. Thank you.